Imagine a patient who was healthy 2 weeks ago. Then suddenly, the urine turns dark like cola. The face becomes puffy, blood pressure rises, and the kidneys begin to fail. This is not just a urinary problem. This is glomerulonephritis, inflammation of the kidney's microscopic filtration units. The glomerulus is the kidney's high-precision filter. It allows water and small solutes to pass, but keeps red blood cells and large proteins inside the bloodstream. The filtration barrier depends on 3 critical layers: fenestrated endothelium, the glomerular basement membrane, and podocyte foot processes. In glomerulonephritis, the immune system injures the filter. This can happen through immune complex deposition, autoantibodies, complement activation, or systemic inflammatory disease. The result is capillary wall damage, leakage of red blood cells, and reduced filtration, leading to activation of the renin-angiotensin system, producing hypertension and fluid retention. The classic presentation is nephritic syndrome, hematuria, red blood cell casts, and mild to moderate proteinuria. Also oliguria, hypertension, and edema. The urine may appear smoky, tea-colored, or cola-colored. Red blood cell casts are especially important because they tell you the bleeding is coming from the kidney itself. One of the classic causes is post-streptococcal glomerulonephritis. It occurs after group A beta hemolytic streptococcal infection, usually following pharyngitis or impetigo. Immune complexes deposit in the glomerulus, producing complement activation. High-yield findings include low C3, elevated anti-streptolysin O or anti-DNase B titers, and subepithelial humps on electron microscopy. IgA nephropathy, also called Berger disease, is the most common primary glomerulonephritis worldwide. Unlike post-streptococcal disease, hematuria occurs during or shortly after a mucosal infection. Rapidly progressive glomerulonephritis is a medical emergency. It presents with nephritic syndrome and rapid loss of renal function over days to weeks. The classic biopsy finding is crescent formation, caused by proliferation of parietal epithelial cells and infiltration of inflammatory cells into Bowman's space. Anti-glomerular basement membrane disease occurs when antibodies target type 4 collagen in the basement membrane. When both kidneys and lungs are involved, it is called good pasture syndrome. Patients may present with hematuria, renal failure, and hemoptysis. The classic immunofluorescence pattern is linear EG deposition along the glomerular basement membrane. The diagnosis begins with urinalysis. Hematuria, dysmorphic red blood cells, and red blood cell casts strongly suggest glomerular disease. Blood tests evaluate creatinine, BUN, complement levels, streptococcal antibodies, ANA, ANCA, and anti-GBM antibodies. In unclear or severe cases, kidney biopsy is essential to identify the exact pattern of injury. Treatment depends on the cause and severity. Supportive care includes blood pressure control, salt restriction, and diuretics for edema, and management of kidney failure. Severe immune-mediated disease may require corticosteroids, immunosuppressive therapy, plasmapheresis, or dialysis. The key is early recognition. Cola-colored urine, facial swelling, hypertension, and red blood cell casts are warning signs that the kidney filter is under attack. Glomerulonephritis is the story of a microscopic filter caught in an immune storm, and recognizing it early can save the kidney.